So thanks, Tina. It's my pleasure to really give you a bit of the background on why best practices sort of inform all of the special projects that you do in stroke. And again, as with Steph, I'm very happy to answer any questions that may come up. When we look at ischemic stroke, and also with evolving evidence that we're seeing with hemorrhagic stroke, is time is brain. And what does that mean? 2 million brain cells die each minute. The blood supply is cut off to the brain in an ischemic stroke. Just 2 million brain cells sound like a lot, but just to quantify it in another way, each minute that we save in reopening the artery, so either with clot busting medication, so thrombolysis, or EVT, grants the person 4.2 days of healthy life gained. We know that stroke is the leading cause of adult disability, and so we really work to improve all of our efforts are to reduce the disability after stroke. So really, time is essential. We know that the ischemic brain ages 3.6 years each hour without treatment. We also know that the longer reperfusion times is associated with the increased likelihood that the patient may die, the less likelihood that the person may recover from their stroke, and the risk of developing intracerebral hemorrhage after treatments. So our goal in our hyperacute stroke management, and so really when I talk about hyperacute stroke management is really that ED, a management of care, is really to restore that blood supply. So with drugs, so either with alteplase or tenecteplase, devices, endovascular therapy, or a combination of TNK and EVT. When we look at thrombolysis, you will see, and this was a change to the recent CHI and a recent change in best practice. Many of you who have been coders have known that we've looked at thrombolysis as being alteplase or TPA since the very beginning when it was introduced. In 2023, a Canadian-based study was done called the ACT trial that compared IV tenecteplase or TNK to IV TPA to see if it was equivalent or non-inferior. What that study found is that IV tenecteplase was non-inferior for patients with ischemic stroke, and 37% of those patients returned to baseline functioning in 90 days. The risk of complications was similar to IV TPA. The risk of intracerebral bleeding was about 3.2%. The risk of systemic bleeding requiring IV blood transfusion was less than 1%. And the risk of angioedema or an airway emergency was less than 1%. Based on that, the Canadian Stroke Best Practices in December of 2022 identified that for all eligible patients with a disabling stroke who receive IV thrombolysis with either alteplase or TNK within 4.5 hours of last known well or symptom onset should be offered. And so you will see within our region 5 of our 6 centers have switched to IV tenecteplase. So Hamilton Health Sciences, Grand River Hospital, Guelph General, Niagara Health, the Niagara Falls site, Joseph Brant most recently, and Brantford will be moving to switch from IV alteplase to IV tenecteplase in the next several months. The difference with IV tenecteplase is it is a one-time IV bolus. And so when you're looking at coding in the project, it is that time that the bolus was given. We know with IV thrombolysis, it must be given with last known well less than 4.5 hours. So another area of the special projects is that symptom onset. And so that is a really imperative and significant indicator that really guides our treatment. We also know that in the best practices in 2023 for the special projects is we really look at a median door to needle of less than 30 minutes and that at least 90% of our patients have a door to needle less than 60. So because we know each minute is so important. Really looking at our thrombolysis processes, as Steph said, really looking at those key markers in that workflow process. Each organization looks at to say, how can we ensure our door to needle is less than 30 minutes? Endovascular therapy, EVT or clot retrieval, is a specialized procedure that is done at 11 centers in Ontario. And those 11 centers are spread throughout the region. So Ottawa Civic, Kingston General, Sudbury Health Center, Thunder Bay Regional Health, University Health Network, Sunnybrook Health Sciences, um, Unity Health, which used to be St. Mike's, Trillium, Hamilton Health Sciences, London Health Sciences, and Windsor Regional. So these are specialized centers that provide this tertiary level stroke care. Endovascular therapy is similar to PCI. It's done in a special angio operating suite. The physicians go through the groin with an arterial puncture, a sheath, into the femoral artery or sometimes through the radial artery. They will feed a guide wire and catheter up to the clot in the artery in the brain. They then will insert this compressed mesh stent into the clot. They'll allow the clot to integrate, and then the physician will remove the clot and the stent from the brain with either manual aspiration or the use of an aspiration catheter. And so you can really see here depicted, these are what some of the different clots might look like. So some are very fibrin-rich clots, some may be more calcified clots that may be sort of an emboli that has come up. When we look at who's eligible for endovascular therapy, it's a select group of patients. It's patients who have clots in the large arteries of the brain. So patients who have clots in the internal carotid artery, the middle cerebral artery, the vertebral basilar. Sometimes we see with patients, they may have what's called a tandem occlusion. So they may have a clot that starts in the internal carotid and extends all the way up to the middle cerebral artery, or sometimes there's clots in both. Patients who are last known well, less than 24 hours, may be eligible for this treatment. These are often disabling strokes. So these are patients, when you're reading the notes from the physician, often have paralysis on one side, usually of their face, arm, and leg. If it's on the right, they may have aphasia, difficulty speaking. If it's on the left, they may have neglect. Patients who receive thrombolytic therapy, so receive TPA or TNK, can also receive this treatment. The reason that is we know these are big clots. Clots more than 8 millimeters in the brain are less likely to be completely dissolved by just IV thrombolysis alone. And so patients before this treatment who had clots in the large arteries and only received IV thrombolysis were often only about 20 to 30% had complete resolution of the blood clot. And so many of our patients, even though they received thrombolysis, were still left with significant disability. So if they can receive thrombolysis and EVT at the same time. However, there are many patients who are not eligible to get thrombolysis therapy, even if they arrive within the 4.5 hour window. So sometimes patients may have had recent surgery, they may have had recent procedures, they may have bleeding disorders, their INR or PTT may be elevated, they may be on anticoagulants, so either warfarin or some of the new oral anticoagulants, so the apixaban or rivaroxaban and doxaban. And many other conditions that may put the patient at increased risk of bleeding with thrombolysis. All of those patients, if they have a clot in the large artery, can receive EVT. I've said, um, with sort of each minute and our treatments, that it's very much as quickly as possible. And a key piece of that is stroke symptom onset. It's so crucial in determining what treatments the patient may be eligible for. As I said, thrombolysis is their last known well, less than 4.5 hours, but endovascular therapy is for their last known well, less than 24 hours. I often describe when I talk about stroke symptom onset, um, it seems like a very simple concept, but it actually can be quite challenging. And I'm sure with the coders, when you're looking at the charts, you'll find, may find that there are differing times that you see in the chart. It's one thing if the symptoms of the stroke are witnessed. That's easy. I'm sitting here and suddenly I stop talking. You see my facial droop. Hopefully, you'll all look at your watch and go that my onset of symptoms is 9:03. The difference, though, is if the patient is found with symptoms, if it's a wake-up stroke, the last known well can be quite challenging, and that's why sometimes you might see differences when you're looking at the reports, looking at what the paramedics will say, looking through the various documentation of last known well, and sometimes it really needs to be a detective to determine when the last known well. So if I went to bed last night at 10 o'clock, um, I woke up at 6 o'clock with symptoms. My last known well would be 10 o'clock. We don't know when the stroke starts in wake up strokes. We also don't know, say, someone was found with symptoms when their stroke happened. So sometimes you may see in reports, for example, the paramedic report will say, the wife will say the patient had stroke symptoms starting at 8 o'clock when he got out of bed. Um, if the paramedics don't ask the wife, or again, the wife is in a crisis and upset because her husband has just developed these stroke symptoms, if the paramedics don't say, "What was your husband like when he got out of bed?" It may not be that those stroke symptoms actually started at 8 o'clock. It may be with further discussion with the stroke neurologist, with the local ED physician at the site, that the discussion with the wife is, well, no, I didn't see him get up. He just woke up with those symptoms. So then that last known well would actually be when the patient went to bed. And so that's why sometimes you'll do see varying um, when you're looking at symptom onset. The focus of the paramedics in the field is really to quickly assess the patient, quickly bring the patient and transport the patient to the closest hospital. And so sometimes it's really more that expert, that stroke expert at the hospital that is really doing that more detailed history to find out when that and confirming that last known well. CT scan, MRI within 24 hours. Again, another key component in the special projects that you do. As I've said, really the best practice would say all patients who are coming in with suspected stroke should undergo imaging. There is no um, tool in the field by the paramedics that can determine if the stroke is ischemic or hemorrhagic. We don't have an ECG as we do with STEMI. Really, our ECG with stroke is our CT scan. And so that really determines whether it's an ischemic or hemorrhagic stroke. It also helps to guide the management and determining eligibility for stroke. We have very different protocols at our thrombolysis centers, and so you may see the different protocols across. So you will see patients will have a non-contrast CT head, again, which is what you capture in the project. It really is looking for ischemia or infarction. You will see at our thrombolysis centers multi-phase CT angiogram. This is where with dye, they're actually visualizing the the arteries in the brain to identify if that patient has a large vessel occlusion and if they may be eligible for EVT. When we look at the late window, so our 6 to 24-hour window, we do another level of imaging at our thrombolysis centers. And this is really to help look at the perfusion of the brain and to help look at where in the brain there's significantly reduced blood flow. The CT perfusion we use has a rapid automated software. And what the automated software does, the AI does, is convert the multiple over 2,500 images of the CT perfusion into simple to interpret maps. And so what you will see on the screen here is you'll see that there's sort of pink areas. That's an area in the brain where there is significant reduced blood flow in the brain. What you will see though here on the screen is the green is an area where there's reduced blood flow, but that brain tissue is viable. This is a patient, an example of a CT perfusion, which is someone who's in the expanded window who is an excellent candidate for endovascular treatment. So even though I may be a wake up stroke and, I wake up at 6, I went, my last known well is at 10 o'clock. What this means is I still have a lot of viable brain tissue, and I would be eligible for EVT. If all of this area was pink, well, then that would indicate that really my stroke has caused damage, significant reduced blood flow to my brain. That area of the brain is dead, likely not eligible for EVT. And so that's why up to 24 hours, even if I had a large vessel occlusion, not everyone is eligible for EVT. ED triage time, Doran time, this is really, when we look at it, is when the patient is triaged in the ED. It is an essential marker because it's considered the door time. And really, when we're looking at our benchmarking times that we monitor at our centers, really looks at our door to needle or that first IV bolus of either TNK or the bolus for that patient receiving alteplase. Also looks at our door to CT. And for patients receiving endovascular therapy, our door to groin puncture. We measure all of these to really ensure that our quality, our processes are achieving the best outcomes to look for quality improvement. So really important data. Switching now to antithrombotic medication. What we know is after ischemic stroke, patients with TIA or ischemic stroke, they have a very high risk of recurrent stroke in the first 30 days. That risk of recurrent stroke is again related to the development of further clots or thrombus happening. What we do know with evidence is the initiation of ASA in the first few days following stroke and continued for the next several weeks reduces the risk of recurrent stroke, early recurrent stroke, and early death. So again, you will see a very important indicator why we capture it in our special projects. We do know that patients who have received IV thrombolysis or EVT, typically that antiplatelet agent or antithrombotic agent is not started until the 24-hour CT scan is done, just to ensure that there isn't any bleeding after thrombolysis or EVT. We also have new evidence, and so you may see this when you're coding the charts, that patients who have a TIA or a minor stroke should have dual antiplatelet therapy, or you may see it called DAP, DAPT. So ASA and Plavix for 21 days to significantly reduce the risk of recurrent stroke and improve the outcomes for patients. You will also find, if they haven't received thrombolysis or EVT, that those patients often then are loaded with ASA, if it's ASA alone, so single antiplatelet agent, then followed by the maintenance dose. If it's a TIA or minor stroke, again, you will see them loaded with a ASA and the clopidogrel, and then continued on a maintenance dose. Oh, sorry, I've just literally said that. Sorry. The next thing we know is patients who have atrial fibrillation should receive oral anticoagulation instead of antiplatelet agent. If the patient is, we know that atrial fibrillation is a significant risk factor for stroke, and 1 in 6 patients are admitted to hospital with ischemic stroke will have atrial fibrillation. And we know that the proportion of patients who have atrial fibrillation increase with age. Atrial fibrillation may be paroxysmal, so it may come and go, or it may be subclinical, and it may go undetected. We know that patients with atrial fib who are not treated with anticoagulation therapy are 3 to 5 times more have a 3 to 5 times increased risk of stroke. And so what we do know, though, is the timing of starting that atrial fib, that anticoagulant depends a bit on how big the stroke is. So a patient who has a TIA should have anticoagulation started as soon as possible, ideally within 24 hours. Patients who have had a stroke with atrial fib should receive anticoagulation with a timing based on the discretion, based on how big the infarct is. If the patient has a very large ischemic stroke, sometimes the physicians will wait just because the risk of bleeding may be high. And so in that situation, you may find, and you may see in the discharge summaries, that the physician will have the patient on antiplatelet therapy with a plan to do a CT scan in 3 days or a scan to do a CT in 5 days and then start anticoagulation. We also know with TIA, a number of patients who are discharged, for those of you that are NACRS coders, that you'll see a number of patients who have TIA who are discharged to secondary prevention clinic and is a key component of SCI-High 340. We know the risk of recurrent stroke is 10 to 20% within the first 90 days after stroke, with half of the strokes occurring in the first 2 days after that initial symptom onset. We have robust evidence that timely initiation of secondary prevention interventions have been shown to significantly reduce the risk of major stroke after that initial TIA or disabling stroke. So our goal within our region is 100% of patients who are discharged from our emergency department with a TIA or a minor stroke are referred to our stroke prevention clinic. We have stroke prevention clinics throughout our region at our sites. We have a stroke prevention clinic at the Hamilton General, at the Niagara Falls site, at Brantford Community Health System, also a satellite in Norfolk. We also have one at Joseph Brant and Grand River Hospital. These stroke prevention clinics is an outpatient clinic who provide expedited assessment and treatment and access to carotid revascularization, so carotid endarterectomy or carotid stenting, provide quick consultation with a stroke expert and access to diagnostic imaging, helps to identify the risk factors for a person with stroke and help provide risk factor management and really provide education for patients and families. So very key that why we measure that. It is also one of our indicators that we report and manage and monitor for ongoing quality improvement. Finally, I'll talk a bit about dysphagia screening, which is again one of the 640 special indicators. And so why do we capture dysphagia screening? Dysphagia screening in acute care can be as high as 65%. Patients with stroke who have dysphagia can lead to aspiration pneumonia, malnutrition, and death. So our best practices indicate the patient should be screened for a swallowing impairment before any oral intake, including food, fluid, or liquids, by an appropriately trained professional using a validated tool. And so what you will see is it can be done by nurses at the bedside, speech language pathologists, registered dietitians, and physicians. What really qualifies as a dysphagia screen is you will see various dysphagia screening tools used across the region. You may see the STAND, this swallowing tool for adult neurological dysphagia. You may see the TOR-BEST. You may see a 3-ounce water test, the dysphagia swallowing test. You may also see a speech language pathologist dysphagia assessment, video fluoroscopy, or a flexible endoscopic evaluation of a swallow or a fees. Ideally, this dysphagia screen should be done within the first 24 hours. You may see it done within the emergency department in the ED notes or on the acute stroke unit.